Hello everyone, let's try to solve this question together. So we have a preterm infant who weighs 750 gram and the patient needs surfactant therapy. An endotracheal tube of size internal diameter 2.5 millimeter, the outer diameter is 3.4 millimeter, is inserted successfully. If prolonged ventilation is needed, this infant is at risk of, so pause the slide and look at the options. What do you guys think? Okay, let's have some discussion points. So basically one point which we all have to know, that usually we use the internal diameter to decide about the size of the tube, but it is important to know the outer diameter because we have to consider the subglottic space in neonates, which I will refer to in slides. So here is a reference. It's an old reference, but basically according to this, the term infants the subglottic lumen is about 4.5 to 5, while preterm is 3.5. The point which I want to make, suppose if you select a bigger tube, this will be very tight on the subglottic space and which can lead to complications later on. The other thing which is very important, this is a very nice recent article published in New Reviews where it says that probably a lower size of the tube is better in terms of intubating babies with less than 800 gram rather than 2.5. But the problem is you have to have a balance. At one end, if you use a smaller tube, you will have increased resistance, you will have easier intubation and less trauma, but low risk of subglottic dilatation or subglottic stenosis. While if you use a bigger tube, the advantage is you can do increased tidal volume, there is less clogging, there is less air leak, but again at the downside is there is a risk of subglottic stenosis. So you have to balance between using these two tubes in smaller babies. So let's go back to the question and see what is the right answer here. So here is the question again. So what do you guys think? So the correct reply here is subglottic dilatation, and this is based on this reference. If you guys have time, pull this article. So basically the article described subglottic dilatation in extreme preterm infants who are on prolonged ventilation. So again, to reiterate the point, the size of the ET tube, although is debatable, like for example, less than a kilo or 1000 gram, usually we use 2.5. But if the baby is small, like 600 gram, probably 2 is better. But again, consider that we will have other advantages by using 2.5 rather than 2. But if tube is tight, then we should not use it. I think so. Again, we have to trade off between some air leak or resistance versus risk of subglottic dilatation or stenosis later on. I hope we all have learned something together today. You guys have a wonderful day. Bye.